Good afternoon, everybody, and welcome. This is the Ohio State University Wexner Medical Center's COVID-19 and Health Inequity Digital Town Hall. What have we learned and where do we go from here? My name is Dr. Wando Olaiwola. I'm professor and chair of the Department of Family Medicine at the Ohio State University Wexner Medical Center and College of Medicine. And on behalf of my colleagues in my Department of Family Medicine, the Medical Center's Health Equity Steering Committee, and our Center for Innovation, Primary Care Innovation and Transformation, we cordially welcome you to today's conversation and thank you so much for your participation. I want to start off with a quote that I love and appreciate so much, and I think that will set the tone for the conversation that we're going to have today. It gives me no comfort that the whole is on your side of the canoe. And the visual depicts a canoe that is going down, but a hole on one side. And what this illustrates is that health equity and health inequity is something that affects all of us. If we have a system where our most vulnerable are deprived and disadvantaged, there's no benefit to the rest of the system. So with that in mind, I'm going to kick off today's conversation and let you know what we're going to do in today's forum. We're going to try to accomplish a number of things in this 1 hour. We're going to talk about current trends in health inequities that have been emerging through the COVID-19 pandemic, talk about how implicit bias and structural inequities have been impacted our response to the pandemic in health and healthcare. We'll then explore public health and community-based strategies to mitigate disparities and build community trust and resilience. And we'll talk about the role of institutions, states, and national leaders to improve COVID-19 outcomes for vulnerable populations. To do that, I'm very excited to present our cast of our presenters today. We are going to introduce them briefly here, and then we're going to all speak one after another. So after I'm finished, we'll hear from Dr. Joshua Joseph, who's Assistant Professor of Endocrinology and the co-chair of the Obesity and Nutrition Steering Committee. He's going to talk about COVID-19 trends and health disparities. Then we'll hear from Dr. Mark Rastetter, who's the Vice Chair for Community Health in our Department of Family Medicine, and he will speak about limitations in public health tools. We will then hear from Dr. Quinn Capers, who is our Vice Dean for Faculty Affairs, and he will speak about the role of implicit bias in compounding disparities. That is our first section, and that will be where we lay out some of the problems. In the second part of our forum, we will talk about the way forward. And where do we go from here? And in this part, you will hear from Dr. Leon McDougall, who is the president-elect of the National Medical Association, the chief diversity officer for the OSU Wexner Medical Center. And he will speak about national level solutions to eliminate post-COVID-19 disparities. Then you'll hear from Chip Allen, who's the director of the Office of Health Equity at the Ohio Department of Health, who will speak about leveraging the state for public health action. Next, you will hear from Dr. Darrell Gray, associate professor and chair of the Health Equity Steering Committee at our medical center, and he will speak about community engagement in mitigating health inequity. And then finally, you will hear from Ms. Autumn Glover, who is the interim president of Partners Achieving Community Transformation, or PACT, at the medical center, and she will speak about building trust through commitment to disrupting cycles of inequality. Following that, we will open up the forum for a facilitated dialogue that will be led by Ms. Candy Magana, who is the director of our Center for Primary Care Innovation and Transformation. You should have the ability to submit questions through the Q&A portion of your webinar screen, and you can share your thoughts and your experiences with us, and we look forward to having that spirited dialogue with you all. So as we set the stage, I just want to share something that was important for us to mention. All the speakers, with the exception of one, are here in the room with me. And I want to make sure that you know that we are taking all the evidence-based public health precautions to make sure that we are all safe at this time. We are all wearing masks while we're in the room if we're not speaking, and we are all sanitizing all the equipment that we're using up here in between speakers. So please feel confident that we're following all the things that we are sharing with you all. So as we think about it, many of you joined this conversation for different reasons, but most importantly, you joined because for some reason, whether the work that you do or the values that you espouse, you support the value of equity. And all these other words that are here on our screen right now are words maybe that are important in your lives and the work that you do, but we're all here for a common reason because we believe and we know that COVID-19 has really exacerbated some existing inequities, and we need to find a way to make sure a post-COVID world mitigates them. So for purposes of our conversation today, we're going to be speaking about vulnerable populations or populations that have been made vulnerable and the impact that COVID-19 has had on them. While we know that this list that you're seeing here of vulnerable populations is by no means exhaustive, we believe that this is just a start for the conversation today. We'll focus our conversation on racial and ethnic minorities in particular, and also low-income folks who are economically challenged. However, we recognize that many other populations have been made vulnerable through this pandemic. We also want to make sure that as we set the stage, we agree that vulnerable populations are diverse. There is no homogeneity in who is vulnerable. On the left side of your screen, you're seeing an axis of oppression that has been created by the Association of Women in Science, through which they describe two different axes for oppression and privilege, and a number of different groups that fall into the oppressed categories. We know also that there's a heavy amount of intersectionality with vulnerable populations or populations that have been made vulnerable. It is very, very common and expected that in many communities, you will have people that have multiple different vulnerabilities. It could be the combination of their race, ethnicity, and their sexual orientation, or something else. So please keep in mind that we're speaking about heterogeneous groups, but sometimes that heterogeneity compounds the risk significantly, and we have seen that manifest itself with COVID-19. Why does it matter that we're talking about vulnerable populations in particular and the health inequities that they face, particularly around the pandemic? For us in healthcare, we know that vulnerable populations are less likely to have health insurance coverage and access to affordable and stable care. They're also less likely to experience quality interactions with their healthcare system, receive the recommended care that they need for prevention, and they're also less likely to have access to things like childcare, transportation, and the ability to leave work to be able to access healthcare. These same vulnerable populations are more likely to utilize emergency departments or have hospital admissions for things that could be managed in an ambulatory sensitive manner. They're more likely to experience behavioral health and substance abuse disorders, more likely to be socially isolated and economically disadvantaged, and more likely to experience housing and food insecurity. However, we only know what we know. Right now, we know that more transparency is needed as we describe many vulnerable populations that have been affected by the COVID-19 pandemic. For example, you might have seen in the Washington Post recently that racial disparities in COVID-19 are probably worse than we think. And looking at the racial data transparency that is being published regularly by the Johns Hopkins Coronavirus Resource Center, we know that only a couple of states, 2 states right now, are actually reporting testing by race. We know that 34 states are reporting confirmed cases of COVID-19 by race. And we know that 26 states are reporting COVID-19 by deaths. So right now we are acting on what we know, but we know for race and ethnicity and also the many other vulnerable groups we described, we definitely need more data. So with that, I'm going to turn it over to Dr. Joshua Joseph, who's going to speak about the challenges in front of us.
Thank you, Dr. Oluwayo. Next. Next slide. So the rates of COVID-19 deaths in 35 states and Washington, D.C., as Dr. Oluwayo described, that the mortality rates here are different. We can see from this slide that Blacks have the highest mortality rates in the United States. Next. When we look right here in Ohio at the COVID-19 cases, and this is from April 8th to April 26th, what we see is that among those cases, 23% of the cases are Black, and Blacks represent 13% of the population, and 50% of the cases are white, and whites represent 82% of the population. So significant disparity. Next. When we look at hospitalizations, we also see a disparity here, where 29% of the hospitalizations are among Blacks, and 56% of the hospitalizations among whites. And you can see the population levels there, again, are 13% and 82%. So a disparity in hospitalizations. Lastly, there is a disparity in deaths, where among the deaths in Ohio, 71% of the deaths have been among whites and 15% among Blacks. Actually, today, that number ticked up to 16% among Blacks. And notably, as Dr. Oluwayo said, the numbers that we have just represent the data that we have on hand. And we know that there are limitations to that. Next. So a summary of these disparities in Ohio is that Blacks are at higher risk of being a case as well as being hospitalized, and a slightly higher risk of death. I did not present the numbers for Latinx groups because in Ohio, Latinx groups represent 2 to 3% of the population, and currently for all the demographics are around 1 to 2% of the numbers. Next. So how are the health disparities impacting that we have at baseline impacting COVID-19? So when we look at the underlying medical conditions in COVID-19 hospitalizations, we see that diabetes, hypertension, and obesity are the three leading underlying comorbidities. Next. And when we look at diabetes prevalence, we know that it adversely impacts African Americans and Hispanic Americans, as well as American Indian and Alaskan Native populations. Next. When we look at hypertension, 40% of African Americans in the United States have hypertension. Next. And when we look at obesity, 57% of African American women and 41% of African American men struggle with obesity. Next. So when we think about all these things together, in normal times, we know that life expectancy at birth is much lower for non-Hispanic Blacks versus other populations in the United States. Next. And so a summary of these underlying health disparities is that there are high rates of diabetes, hypertension, and obesity in African American populations, which are risk factors for SARS-CoV-2 and COVID-19 hospitalization. There's higher mortality prior to and during the COVID-19 pandemic. And for Latinx populations, specifically in Ohio, there are high rates of diabetes and obesity and a higher mortality during COVID-19, particularly on the East and West Coast. Thank you very much.
Hi, everybody. Yeah. All right. So, hey, everybody, I'm Mark Rastetter. I'm Vice Chair for Community Health at the Department of Family Medicine. We're just working through getting my slides up here and running. So, all right, there we go. All right. So we're seeing this pandemic compound risk for the most vulnerable. A Pew study last week asked, have you or a family member needed to take a pay cut or lost your job? 52% of low-income respondents said yes, different when compared to their upper or middle income counterparts. Broken down further, I want to draw your attention to two areas. Looking at race, paying attention to the gray boxes here. Those identifying as Hispanic either lost their job or took a pay cut, looking at 44% of Black respondents. Similar trend for those with less than a college degree. Dr. Joseph spoke about national and state data regarding mortality and hospitalization. We saw a concerning trend for racial and ethnic minorities. I want to discuss testing as it applies to race and ethnicity. For the most part, as Dr. Aliwala said, we don't know. 2 states, and kudos to those 2 states, are looking and tracking this data. Let's look at Illinois, for example, where Black patients make up 38% of deaths, 22% of confirmed cases, while only being 13% of the population. Black patients are only 13% of those tested. Now, also in this data, there are many left blank answers. So we're seeing overrepresented in death in confirmed cases compared to their percent population, underrepresented in testing, given the effect the pandemic is having on their community. Testing allows action and prevention. This is a compounding problem, and one will need to, and we'll need more data moving forward in this pandemic. So what does this all say? Well, when we look at a quote here from 2013, severe illness and death rates tend to be higher for racial and ethnic minority groups during public health emergencies. This is something we've known, and this is something that's playing out currently. It's a compounding effect for the most vulnerable. It leaves more questions. Questions like, if we can start collecting data and getting good data on race and ethnicity, can we make it specifically actionable for those communities? Are our diagnostic algorithms of who needs testing designed with vulnerable communities in mind? and contact tracing going to be so important moving forward? Who will be hired? Hopkins reports that we'll need an extra 100,000 contact tracers and that a bachelor's degree is not required. Are we going to be looking to the communities most affected by this? I believe the answer to these, to understand the data, we need to be looking at this through a lens of health equity. Things like housing density, employment, food access, burden of disease. Otherwise, we're going to design systems, recognize they were broken, for our communities made vulnerable, and be left, as usual, patching together an ineffective safety net. I'm going to pass it over to Dr. Quinn Capers now.
Thank you, Dr. Rostetter. So I want you to take a look at these putative coronavirus patients. There are 4 of them. Our unconscious minds, based on experiences we've had our whole lives, can associate certain concepts with what we see when we look at people. So that as we look at these 4 patients, we might have an unconscious association with love, with the concept of family, with the concept of noncompliance, or even the concept of danger. And I'd ask you to consider how it might impact your prescribing if you associate this person's appearance with noncompliance. How it might impact your referral for testing if you associate this patient with noncompliance, and how it might impact your mannerism as you approach this patient if you associate their demographic with danger. Where is the bias? It turns out the bias is both at the individual level, the doctor, the pharmacist, the nurse, et cetera, but also in the system. And the system itself is biased against the populations that we're discussing today. So that if you think about the messages we've been sending out, the message we've been sending out is, if you think you are sick, if you think you're ill, don't come to the emergency room because there could be particles there and you might overwhelm the system. Call your PCP. Well, if you're uninsured or underinsured, or in these populations we're discussing, you might not have a primary care physician. So the message is, if you have a headache, a fever, a cough, then just stay home and keep coughing. Social distance. The ability to social distance is a marker of privilege. If you live in government project housing, if you live in a multi-generational household, you might not be able to stay 6 feet away from everyone. Working from home is another marker of privilege. If you work at a fast food restaurant, if you are a janitor, if you work in the hospital as a nurse or a nurse's aide, you can't call your boss and say, I'm going to work from home next week. And then finally, the location of the testing is critical. So where are these testing sites? They tend to not be in the neighborhoods and the communities that we're discussing. At the individual level, it is known that doctors might unconsciously associate a Black person with danger, pain, or misery. Might unconsciously associate a Black or Hispanic person with noncompliance. And there's data that consciously doctors might endorse false biological beliefs, such as Blacks have thicker skin and fewer nerve endings and may therefore be less likely to feel pain. So what is the way forward? In practical terms, we do have something we can do. Systemically, we need to make sure that our decision-making bodies and committees are diverse and have representation from diverse communities. When we are making policy, the meeting is not over until we've considered this question: how will this help or hurt the populations we're discussing? And we need to go out of our way to enter minorities and other disadvantaged persons or from these communities into research on vaccines, treatments, convalescent plasma. There's a lot of research going on right now. Let's make sure that our research populations are also diverse. Individually, it turns out we can overcome our implicit biases. It just takes awareness and it takes practice. And we do that in our implicit bias workshops, and we feel all healthcare providers should have this kind of training. It's also important to be culturally humble and culturally competent to truly have respect for all cultures. And then finally, we need more diversity in medicine. This is a long-term fix, but let me tell you, we are in a crisis, but we will get through this. We will. But another one will come. It might be 10 years from now, it might be 30 years from now, But if we work now to diversify medicine, then maybe when the next one comes, we'll have a physician workforce that reflects the diversity in our population, and that will save lives. Thank you. We've talked about the problems. Now we're going to transition to talking more about solutions. Dr. Leon McDougall.
Thank you, Dr. Capers. I was asked to present this afternoon on providing national level solutions to mitigating health disparities post-COVID-19. So what does that mean, Dr. McDougall? It means that we must invest in communities disproportionately affected by COVID-19. And you see the outline here that we'll be discussing. I have 3 minutes, and I'm going to break this down in 3 minutes. Number one, we should triple the investment in historically Black colleges and universities, Hispanic serving institutions, and tribal colleges and universities. I'm calling this opportunity endowments. Thank you, brother. In addition, we must provide cross-sector, private, public, cross-sector support for students from those communities. And what should that look like? That would involve, for family incomes of less than $120,000, that those students would pay 0 to 10% of their family income for total cost of attendance. Number two, another opportunity endowment, cross-sector investment in supporting a social and legal justice institute, enabled to reinforce and invigorate efforts to reform the criminal justice system. This would involve helping to protect African Americans and communities of color disproportionately impacted by COVID-19 from manifestations of what Dr. Capers spoke to, bias, such as mass incarceration. Next slide. And lastly, we need to tackle that wealth gap. And again, engaging in private, public, cross-sector investment to create a Wealth Disparities Institute to reinforce and invigorate efforts to create wealth within the African American and communities of color disproportionately impacted by COVID-19. Thank you.
Good afternoon. Thank you, Dr. McDougall. Our speakers have done a great job of outlining the risk factors for COVID-19 and also some of the social determinants of health. What I'd like to do very briefly is to talk about how that information and what they talked about, how does it really manifest itself in local communities. So what I'd like to do is focus on one of our great cities in Ohio, Youngstown, Ohio. On the left, one of the things that you see are prevalence rates of underlying conditions for COVID-19 that have been projected to Youngstown. And if we then begin to ask the question, where do these underlying conditions occur at their worst levels? We see 3 census tracts that actually come up, 3 census tracts or neighborhoods. We also see that when we look at the demographic analysis of this information, African Americans and Blacks are overrepresented and 5% of the population are Latino. There's one important thing that we need you to understand about this slide. We're not saying that just one of these conditions exists at their worst levels. All 6 of these conditions exist simultaneously at their worst levels in each one of these neighborhoods. And then when we start to take that same methodology and look at it across other major cities in Ohio, we see a pattern. First of all, we see that African Americans are most likely always the majority of the population in these areas. But we also see another thing. We're talking about not only disparities, but inequities. There is nothing natural about African Americans being overrepresented in these numbers. It is an equity because there is a systemic problem that is based on some type of underlying social injustice that's causing these issues. And so when we think about what's causing these issues, at the Ohio Department of Health, we have a tool called the Health Opportunity Index that allows us to understand what social determinants are driving for health outcomes. As you look at all the cities represented here, one of the things that you'll find is that concentrated poverty and income inequality are always represented. So as the other speakers said before me, if we do not address these social determinants in a meaningful way, we will not be able to not only address these issues, but issues like COVID-19. And so we start thinking about state level solutions to actually be able to address these issues. We really need to think about broad-based policy changes that lead to economic security. We need to understand that there are many vulnerable populations, but some vulnerable populations are more vulnerable than others. And the solutions that we need, legislative action, we heard about justice reform, and we also need transparency in terms of testing and to be able to understand the burden of disease. We also have to confront the racialized health outcomes because there are unfair opportunity structures at the state level and also at the local level that's causing the problems that we see. And finally, as we think about any state level solutions that we come up with, they cannot work without the wisdom and input of our local partners. Thank you so much, and now I'd like to turn it over to Dr. Darrell Gray.
Good afternoon. I'm Dr. Darrell Gray. And so thus far, you've heard about the disparities amongst populations made vulnerable, and you've heard about even potential solutions. You've heard the description of the problem by Drs. Joseph, Rostetter, and Capers. And then you've heard about some national solutions from Dr. McDougall and possible state level solutions by Mr. Chip Allen. What I'd like to submit to you is that none of those solutions have any chance of being achieved without community engagement. But let's take a step back. And I want to use this illustration to describe something. So in public health circles, we often talk about downstream and upstream, downstream factors being the result of upstream issues. And so, you know, anytime we're talking about social determinants, and again, social determinants describe the conditions in which people live, work, play, and pray, and the larger forces that impact those conditions. Certainly, we cannot be discussing as a society the problems of COVID-19 and comorbidities without also discussing the upstream factors that contribute to this. So as we keep this illustration in mind as we further discuss this. So certainly, headlines have been talking about COVID-19 and particularly the comorbidities or other diseases that can contribute to worse outcome amongst those who have COVID-19. But certainly, what's important to discuss amidst that is what are the conditions in which they're living? Food insecurity, unsafe and overcrowded housing, exposure to toxins, air pollution, income inequality, with the wealth gap that was described in earlier slides, poor access to high quality healthcare, education, and unemployment. But certainly, well, what contributes to that? We have to go further upstream. And we cannot ignore as a society the impact of poverty, racism, and discrimination. Let me say that one more time. We cannot ignore as a society poverty, racism, and discrimination as contributing factors. Again, there's interaction amidst all these levels with biology, behavior, and environment. So certainly there are behaviors that contribute to development of disease, but what are those other environmental factors that contribute to that behavior and other factors? Now, certainly, like I said, I submit to you that community engagement is necessary and vital for us to be able to address upstream, midstream, and downstream factors that are leading to what we're seeing today amidst COVID-19, in the past, and in the future. Hopefully we can shift the narrative. And what community engagement allows us to do is it allows us to be at the table when policies are made. It allows us to impact political will. And when I talk about the community, I'm not just talking about lay community people. I'm talking about our banks, our policymakers, our private sector partners, whether they be business partners or otherwise, and our direct community organizations as well. And what these organizations do, they help us to build collective efficacy, social capital, resilience amongst the population, and capacity building that will ultimately allow us to have healthier communities, addressing those midstream and even those upstream factors that I described. Now, we have some examples here in Ohio, particularly in Columbus, that do this well. We think about organizations like the National African American Male Wellness Initiative and ETSS, as it's affectionately known, or Ethiopian Tewahedo Social Services. These groups address disparities within African American and New American populations respectively at all of those levels. And I'm happy to play a small part and role in that. Thank you. And now we'll transition to Mrs. Autumn Glover to talk further about community engagement. Now, lastly, as we transition to Autumn, I want to leave you with these two quotes. Every system is perfectly designed to get the results that it gets. And true compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring. Our system is perfectly designed to get the disparities that we're seeing now. I submit to you that community engagement is part of the solution and is part of the restructuring. Thank you.
Good afternoon. The COVID-19 crisis arrived in a society already sick, reminding us clearly of our greatest inequities. Relief from the COVID-19 crisis is directly connected to relief from systemic cycles of inequity, addressing the social determinants of health, as Dr. Gray and Chip Allen have shared. Quality and affordable housing, access to transportation and healthcare, high quality education and economic mobility, a meaningful life with social connections. Today, many understand that these factors impact health. The fact is, healthy communities produce healthy people. COVID-19 will change our society, and our response to this crisis and the chronic conditions of our communities should also shift the mission of our work. In this moment, we have the opportunity to establish policies and practices for the next generation. Previous policies like redlining that kept Black and brown people trapped in urban poverty were developed in times like these during the Great Depression. This is our time. Let's not look back in 50 years having perpetuated these poor conditions for vulnerable populations. It requires, as Dr. Gray referenced, cross-sector collaboration, people from different areas of expertise, anchor institutions together with business, government, local nonprofits and CDCs, school systems working alongside the people living in the community. Engaging with the community means engaging with people, proximity to people to address their community problems. Importantly, this approach requires empathy and cultural humility. I think it's important to convey that cultural competence that Dr. Caper shared with us is recognition. Humility is action. It's the practice and behavior of seeking to understand individual and collective culture, building relationships actively. People have a wealth of power in their combined social capital, the networks, norms, and trusts that enable participants to work together. Being in community with each other is how vulnerable populations have been resilient through tests of time. In crisis and in practice, funders and leaders can leverage existing relationships and trusted brokers. Funding and partnering with organizations who know the most vulnerable is critically important. Dr. Gray highlighted a few of ours in Columbus, Ohio. Long-term, an approach worth replicating is the place-based work Wexner Medical Center has invested in for nearly 10 years, Partners Achieving Community Transformation, or PACT. PACT is a nonprofit community quarterback formed in partnership with local government, the Public Housing Authority, and community stakeholders. We spent nearly 2 years engaging the community to develop a plan for transformation on the historic Near East Side of Columbus. This is an example of working with the people to address the social determinants of health they face. An integrated, holistic system also dismisses the assumption that there's one lever or a silver bullet responsible for fixing all of this. People in economically blighted communities are deserving and typically deprived of the same fundamentals that all people benefit from: safe and quality housing, supportive health and wellness resources, and a high quality education pipeline from birth through college and career. This model of place-based and community-driven work is being replicated through a network of community quarterbacks in cities like Atlanta and New Orleans, Orlando, through a network called Purpose-Built Communities, and is one example of how cross-sector collaborators can pursue health equity for the long haul. I leave you with a reminder of the Stephen Covey quote. It's a concept credited to Covey, really focusing on organizations, but I think it clearly applies to communities and neighborhoods as well, which means that change takes time and can only happen if we have developed trusting relationships with our partners and a real value for their contributions. Finally, Jane Jacobs reminds us that together we can build healthy communities and achieve health equity. We invite you to join us for question and answer.
Hi, everyone. My name is Candy Magana, and I'm the director of the Primary Care Innovation and Transformation Center at The Ohio State University. Thank you to our panelists for giving some great presentations today. And now we're going to transition on to our facilitated dialogue for our town hall. So our first question is directed towards Dr. Gray. We actually have a couple questions. So where do we begin to fight inequity, upstream or downstream? And how can safety and testing be amplified in communities in Ohio, at Ohio State University, Ohio Health, and at Mount Carmel?
Thank you very much for that question. Certainly, I think, number one, to be able to address the upstream factors, we have to call it out for what it is. And so we have to ensure that everyone is aware, including all our different partners. So our partners from government on down into our community stakeholders, businesses, banks, et cetera. Part of the issue, as we talked about, that I didn't get into in detail, as we think about discriminatory policies or actions, we think about actions such as redlining that kind of discourages investment into certain neighborhoods. So that has to be addressed. And it takes everybody's voice to do that. So even those who are living in those conditions to those who are trying to help those in those conditions, they have a voice. And so making that voice heard is one important piece. I think going to the second part of the question, certainly partnership across health systems, talking about OSU, Mount Carmel, Ohio Health, et cetera, is very important as we try to address not only the downstream effects, but also the upstream ones as well. I highly believe that healthcare workers can contribute to addressing all of these factors and are not just purely trained as healthcare professionals per se, treating disease, but also treating those things that lead to disease as well. One of the things that I'm really excited to announce along these lines is that OSU Wexner Medical Center has now committed to distributing 36,000 masks in Ohio, particularly in Franklin County. Again, let me repeat that. Ohio State University Wexner Medical Center has now committed to distributing 36,000 masks, particularly amongst those who are made most vulnerable during this time. And we have a targeted strategy that you'll be hearing more about in the coming week in regards to how we're going to distribute these masks, but that also pertains to testing. We're trying to work with our partners to figure out the best way by which we can deploy targeted community-based testing to address some of the needs that we've been describing today.
Thank you, Dr. Gray. So our next question is directed towards Dr. Capers. Do you think that using the term bias is a proxy for the more charged terms like racism and homophobia?
So racism, homophobia, these are types of biases. So there really is some overlap between the terms. But we like to talk about implicit bias, the ones that are outside of our awareness, outside of our control, and explicit biases. So if I am consciously aware that I have a negative attitude about a certain group, that is a conscious or explicit bias. So racism, sexism, homophobia, transphobia, these are examples of explicit bias. We spend a lot of time today talking about implicit bias, the ones that are outside of our awareness, and those tend to be really insidious because the people who are discriminating based on implicit biases actually think they're doing a good job. And so they are maybe even more of a challenge. But there is a lot of overlap in those terms. Racism is a bias, but it's an explicit as opposed to implicit bias.
Our next question is directed towards Dr. Joseph. Does COVID-19 make diabetes worse, or does having diabetes make people more susceptible to COVID-19?
Thank you for that question. I hope that you can see me, and if not, you can hear me. That's an excellent question. The COVID-19 pandemic has really elucidated and shown a bright light on many of these disparities that we see, one of them being diabetes. And we know that there are a high percentage of individuals that are hospitalized with COVID-19 that have diabetes. A couple of the reasons why that is because individuals with diabetes, particularly uncontrolled diabetes, are at a higher inflammatory state. And so when they're in that higher inflammatory state, they are at higher risk for different morbidities from COVID-19, as well as mortality from COVID-19. Interestingly enough, in the United States, when we think about type 2 diabetes, there is also coexistent obesity in many of cases of type 2 diabetes. And we know that obesity, interestingly enough, with a body mass index greater than or equal to 30, is the leading contributor to those individuals who are hospitalized requiring mechanical ventilation. Once again, obesity is the leading contributor of those that are hospitalized requiring mechanical ventilation in those particularly under the age of 65. So we know it's really this mix of diabetes, hypertension, obesity together that is really increasing risk for both morbidity and mortality here in the United States.
Thank you, Dr. Joseph. Our next question is directed towards Mr. Chip Allen. Ohio's Governor DeWine, has just assembled a minority strike team. In your opinion, how can this team be most effective? What should be their focus?
Well, thank you for the question. So the minority COVID-19 strike force it has a very tough job ahead of it for a couple of reasons. Number one, the strike force has to not only deal with what are we currently doing with our response, but also what are we going to do in terms of the recovery. We have a number of very talented people on the task force, and they're very committed to actually making sure that we address not only the immediate problems, but we have to start focusing on some of these longer term issues that really make issues go out of control in terms of COVID-19. The other, I think, very important aspect of this strike force is being able to understand what the governor and Dr. Acton are considering so that we can provide the proper guidance, or at least the recommendations, to assure that when we make plans to, like, for example, reopen the economy, that we do it with these vulnerable populations in mind. Just because, for example, that we might reopen the economy doesn't make these vulnerable populations necessarily safer. So what this strike force can do is to provide the governor and Dr. Acton and all the other decision makers information that they need so that we can have the best outcome possible. Thank you.
Our next question is directed to Dr. Olaiwola. Should we focus on clinical care, public health, or community engagement first? And are these problems unique to the United States?
Thank you very much for those questions. I'll take the first question, which was, where should we focus first? And in answer to that, I would say, yes, I think we should focus on all of them. I don't think that we can separate clinical care and the delivery of care from community engagement, from public health. I do think that we can take concrete actions in all of those different areas to make sure that we are preparing ourselves, as Dr. Keeper said earlier, to be positioned to handle the next pandemic when it comes, but to mitigate the aftermath of this one. So my answer to that is really that we should be focusing on all three. We cannot separate or disentangle any of those from the other. The second question. Okay, the second question is, are these problems that we're seeing with health inequities unique to the US? That's a fantastic question. I do want to share that, sadly, the answer is no, it's not unique to the United States. We're actually seeing some very disturbing trends in many other countries, in Europe, in Asia, and in the African continent. So we are seeing a significant problem with disparities all over, combination of race and ethnicity, economics, as we've talked about, orientation, religion. So unfortunately, structural inequity is present all over the world, and we have work to do in many other countries in the United States. Thank you.
This question is directed towards Dr. Rastetter. Can you comment on the paradox that people who have less income are more likely to lose their income with COVID-19? And also, could you also talk about the role of community health workers during this time?
So those are great questions. I think when I heard that first question, the first thing I thought about is people experiencing homelessness. We know that people experiencing homelessness, for instance, can come in and out of having income, of being homeless. And I think that's the issue that we're seeing with some of the most vulnerable. The people that are having, that have the jobs that are most likely to have been cut in this pandemic have been our lower income respondents in that study. And so I think that is what we're seeing, and all of a sudden there's an emergency. It's going to affect the most vulnerable because they're most at risk. I think the community health worker question is a great one, and the thing that came to my mind was in the ideas of contact tracing and how important relationships are going to be in confronting this pandemic and addressing it. So when I think about that idea of getting 100,000 contact tracers across, I think of our community health workers having already established relationships, right, with the community. And I did put in there that idea of increasing our staffing, increasing our community health workers in this period of time is going to be so important. And I made mention of that idea that the Hopkins report said that there was no need for an undergraduate degree, right? So a lot of the people and names I've been throwing around for contact tracing sometimes are people with graduate degrees. And so I think looking at how we can look at the communities most affected and build a workforce and an infrastructure to have established relationships is going to be hugely important as we look at this moving forward. Thanks.
Our next question is for Ms. Autumn Glover. I'm an individual. What can I personally do to fight health equity? So that's the first question. And we have a second question for Ms. Glover on community engagement. How can we do this while social distancing?
So I think at the individual level, the most impactful way to get involved with advocating for health equity is to get engaged in your local community. So if you don't know your neighbors, that's the first step. If you're interested in working in communities and you aren't a part of a vulnerable population and you don't live in the communities that are hardest hit, then you need to engage with some of those local trusted brokers that Dr. Gray and I referenced to see how you might help. The other thing that I think cannot be understated is you need to vote. You need to be paying attention to the politics of your local government, of your state government, and at the federal level. I know in Ohio, we just had our primary election. That's critically important. fill out your census and be aware, cognitively engage in your community so you know what's happening. And if you have levers to pull them. If you observe opportunities to advance conversations around high quality education and housing, do that. Everybody has a role to play. You don't have to have a big checkbook to engage, but the key is that you have to engage. As it pertains to community engagement during this time, it is a challenge. And so I'll tell you just very practically some of the things we've done at PAC, but I'll tell you, this is one of the burning questions that I go to bed with every night during this pandemic. So first, we have continued all of our community engagement programming using Zoom. We've been calling people individually. Today in Columbus, we're doing a buy Black Thursdays. And so I've personally been purchasing from the local businesses in our PAC neighborhood, sending treats to people in the community. I can't eat it all. We're talking about health, but trying to support the local businesses in the community is one way that we're engaging in social distancing times. We're using Zoom to connect with our neighbors and picking up the phone. Our ability to do that is because we have already been building those relationships over the last 10 years. So I have someone's phone number and their email, and I'm able to connect with them via Zoom. The challenge is that many of these communities are suffering with lack of access to technology. And so one of the things that I think we all need to be thinking about is access to technology as a public right and access to technology as a utility. And so digital divide, I think, is the next phase for us to think about community engagement, that access to the internet and technology is not a luxury, but it's going to be directly connected to our ability to connect with each other, to connect with jobs, education, and so forth. So hopefully that answers the question. Thank you.
Our next question is for Dr. McDougall. Has this pandemic revealed any intersections between medicine and policy that were more concealed in the past? And if so, how would you recommend future medical and health professionals immerse themselves in policy, particularly healthcare policy, to be more well-rounded and informed moving forward? And the second question for Dr. McDougall is, nationally, how can we encourage communities to take social distancing seriously?
Thank you. Very good question. So the first question, as a health professional, I would encourage everyone to join your professional organization. With me serving as president-elect of the National Medical Association, I serve on the Health Policy Committee for the National Medical Association. And that has allowed me to engage and be a part of discussions with Rainbow Push Coalition, and other organizations. So join your respective professional organization, get involved and participate in those committees that will allow you to leverage your expertise and your passion to advance policy and talk with stakeholders. In regards to the second question, could you repeat that again?
Nationally, how can we encourage communities to take social distancing?
So that again involves giving and providing messages through trusted messengers. We've had a number of actually all of the people who spoke with you this morning are trusted messengers within the communities, and developing culturally sensitive, multilingual messages delivered by peers would also be important. So if we're dealing with a younger age group, having messengers who are known within that community and who are influencers, and then using the various platforms for communication, whether it be through social media or radio, television. So it would be a multifaceted approach. So joining organizations that have policy committees and focus on policy, NAACP, Rainbow Push Coalition, your respective national organization. That's how I would approach that.
Our last two questions are directed towards Dr. Quinn Capers. How can you call out structural racism without alienating those that are uncomfortable? And the second question is, how do we tackle the concern about Black and Hispanic men wearing masks?
Thank you. So how can you call out, bring attention to structural racism and bias without alienating good people that really want to be a part of this solution? I think all of it has to do with tone and with what's in your heart when you make this communication and how you communicate. So I have to believe that everyone in this fight with us, and we're all in this fight together, is coming from a place of a pure heart and with good intent. And so if you let people know in a non-threatening way that this structure is set up to disadvantage certain populations, I do think people of goodwill will listen to you. But let's be sure that we're communicating in a respectful way, realizing that everyone wants to help. The second question is one that's very important, and I'm very proud, actually, of one of our staff members at Ohio State, Aaron Thomas, for being one of the first ones to bring attention to this, and that is this fact that some Black and Hispanic men are having to choose between saving their lives by wearing a mask and perhaps putting their lives in danger by being a brown or Black man with a mask on. So this is a major problem. It has to do with both implicit and explicit biases. We all grew up seeing the bandit or the robber or the thief wearing a mask or bandana. When you add to that the implicit bias about Black men and brown men might literally be putting their lives in danger by going out with a bandana. So we're going to call on the state to make more medical, surgical looking masks available. We're going to call out to our wonderful law enforcement partners, say, let's recalibrate your brain a little bit. We're in a pandemic. People are wearing face coverings, so not everybody is a bandit. And we want us all to be working together as a team. So be careful out there. If you have one mask and one bandana, maybe give the bandana to your daughter, but the man needs to wear the surgical mask. But we need everybody thinking like we're in a pandemic and we're working together. Thank you.
Thank you so much, everybody, for your very thoughtful questions, examples, and challenges to us in the chat. We're unable to get to all the questions, so we just want to make sure that, we will do our best to try to get the answers to those questions that you've asked when we send out further details after the conversation today. So we are going to bring this to a close with a few parting thoughts. I do want to just make sure that I take a minute to acknowledge my team that has been working behind the scenes from the Department of Family Medicine, Candy Magana and Ashley Harmon, and all the other members of our team who have been working tirelessly to bring this to happen, in our communications team. And as I mentioned, the very senior leadership of our College of Medicine and Wexner Medical Center, as well as the Ohio Department of Health. So thank you to all of those folks. And thank you to our partners that in co-hosting this event, the Department of Family Medicine, the Health Equity Steering Committee, and the Center for Primary Care Innovation and Transformation. So we're going to leave you with a few parting thoughts. And I think that we've really, hopefully, inspired a lot of dialogue, but more importantly, that we've inspired a lot of action. And that you can think of some ways when you go back to the communities that you serve and that you take care of and where you are invested, ways that you can help make those communities better and address the health inequities that you're seeing right now. We are going to leave you with a few thoughts, and those thoughts are just thinking about, how does that implicit bias lurk in the work that you do? Will you be able to address it, and how? Are your testing protocols and the screening protocols that you have designed through a lens of health equity? Are they designed so that they will take care of the patients and the communities that are most vulnerable? We know that vulnerability, as we talked about, includes multiple groups of people with multiple intersections, and we know that there's no homogeneous group. Who are the people that have been made most vulnerable in your community, and how can you serve them better? How will you now go look at data by race and ethnicity, by gender, by religion, by income? How will you look at all that data more critically? And if you see that that data is not being provided, what will you do with that data? There were questions in the chat function, a few questions about how will you use predictive modeling to decide which communities could be targeted for intervention or for support or for resources as you're thinking about resource allocation. Then do you work with underrepresented minorities in the various sectors that you're in? Do you make sure that when decisions are being made, that those folks have a seat at the table? And can we make sure that's true and real going forward? You all are involved with organizations across your local areas, in your state, and in your communities, and maybe at the national level. How will you personally get involved with those organizations to push an agenda of health equity? And finally, how will you talk personally to your family, your friends, your colleagues about COVID-19 and the devastating effect that it's had on so many different communities that have been made vulnerable? So think about these things. Remember that this is a problem that we're facing all over the world. And most importantly, we want you to keep in touch. Please continue to send us your ideas, your thoughts. We have an email, coronavirus@osumc.edu, where you can send additional questions, and we'll do our best to make sure that our experts answer them. You can visit us online at our various websites for the OSU Wexner Medical Center, the Ohio State Department of Family Medicine, and the Center for Primary Care Innovation and Transformation. You can hear more about our Health Equity Steering Committee work. And please, we ask if you can please take the post-event survey. That would help us enormously. That will help us think of what future programming that we at the Medical Center can provide, and also who joined us and more of what the needs that you have in your various communities. We thank you so much, and we hope that you will work as hard as we can to make sure there are no holes on any side of the canoe.